section is on substance abuse and dependence for behavioral science and psychiatry for Falcon Physician Reviews. So drugs, alcohol, tobacco are a major problem in the United States. And nicotine is the most commonly abused drug in the United States. About 50 million people are dependent on the nicotine. Next, you'll have alcohol, where there's about 12 million people have a problem with it. Cocaine, 2 to 3.5 million are dependent. And heroin, about 800,000 to 1 million people are dependent. So what are the different health effects of drugs? Number one, it can cause infections. Frequently these patients are very impulsive, have poor decision making, are sharing needles, having sex with people who they don't know, and they don't know if they have these illnesses. And the two big ones are hepatitis B and C, as well as HIV and AIDS. Next, another big problem is gastrointestinal pain and bleeding, especially from alcohol. These patients will have varices and ulcers, perforating ulcers, which will bring them into the emergency room. Also, you'll have brain and peripheral neuron damage. Alcoholics will have dementia. Also, young kids who are sniffing aerosol bottles will have problems with dementia and cognitive impairments. And cardiovascular one is also a very important health effect of drugs. Frequently, you'll see 30-year-old patients who die of a myocardial infarction or who have a stroke because of a cocaine overdose or an amphetamine overdose. So these are very important health effects of drugs. As you can see in this table, nicotine is a highly addicting drug, and about 32% of people who use nicotine become dependent. So not only is the most common drug that's used, but it's also the most highly addicting, followed by heroin, cocaine, alcohol, marijuana, and anxiolytics. So what makes a person an addict? First, there has to be an addicting drug, a susceptible person. So do they have some kind of family history of drug use? Are they having a personality problem? Are they just not very resilient? And also a mechanism that brings these two people together. So are they from a lower socioeconomic status? Did they have some major psychosocial stress that they can't deal with? So these are the three main things that will make someone an addict. So who is a susceptible person? Family history is very, very important in a drug history. Also, you'll notice a higher concordance in monozygotic twins versus dizygotic twins. Psychiatric comorbidity. Frequently, patients who have depression, anxiety, and antisocial personality will have already started taking drugs and alcohol. And the reason why they say they take them is because, oh, I was self-medicating, I couldn't get to a doctor, the alcohol, it really helps me with my nerves, or taking some marijuana gets my mind off of things, it really slows me down, and that really helps with my anxiety. So frequently patients will use drugs to help them treat their mental illnesses. Also, there are other psychosocial risk factors, such as being male, being from a lower socioeconomic status, unemployed, and if you're someone who's susceptible to peer pressure, then you'll have an increased likelihood of using drugs. So what brings these two people together, the drugs and the people? Well, first, it's the physical dependency for it, or the physical need for it. So if you're having any kind of mood problems or anxiety problems, or if you're having any kind of pain, that's what's going to drive you towards these drugs. Economic. Frequently people can make lots of money off of these drugs. It is pretty quick, pretty easy, just have to be a little bit careful. Psychological reasons, legal reasons, and also role of poverty. So the most important point on this next slide of the physiology of substance abuse is the dopamine reward pathway. Now, I don't expect you to memorize this whole pathway, but the most important point you must notice is the nucleus accumbens is your dopamine reward center. So when a person takes stimulants or opioids, it goes to this center, and it creates a feeling of reward, a feeling of happiness. And this is what makes the person feel good and want to repeat the behavior and causes them to be addicted to it. So the nucleus accumbens and the dopamine reward pathway is an important point for you to remember for your exam. So what is abuse? Substance abuse is a pattern that is shown to be maladaptive and leads to distress, manifested as one or more of the following. So you're using a substance even when you know it's physically hazardous. You're using it despite there's social interpersonal problems. There's legal problems such as DWIs or driving while intoxicated or public intoxications. and you fail to fulfill obligations at home, work, or school. There is a mnemonic in your book that can help you remember what substance abuse is. Now, how do you differentiate substance abuse from substance dependence? Now, I don't think you need to memorize this criteria for USMLEs, but if you can remember that in substance dependence, you have to have at least 3 of the following on your slide to be a substance dependence. And there'll be tolerance and withdrawal. Now, either of those are not necessary for substance abuse. So if you see a vignette where someone has tolerance, which means that they have to drink more in order to get the same high, or when they stop using the drug, such as alcohol, they start shaking, they've had a seizure, well, that would automatically point you towards substance dependence. Because the criteria is very, very similar, but these two are very, very different, and if you notice any of these criteria, then you automatically know that you're looking at a substance dependence and not just abuse. Because in both, you still will have excessive use, problems in your social occupational functioning, and you'll use it even though you know it's physically hazardous. Other important points that differentiate substance dependence from abuse is that it's hard to cut down, and you will try to take excessive time to find the drug. So what are the different categories of drugs? First, you have the sedatives and the depressants, such as alcohol, barbiturates, and benzodiazepines. Then you have your stimulants, which are your caffeine, nicotine, amphetamines, and cocaine. Then your opioids, which are morphine, heroin, and prescribed pain medication. Your hallucinogens, such as marijuana, LSD, PCP, psilocybin, mescaline, inhalants, solvents, and others. So what is the physiology of substance abuse? GABA is a primary inhibitor of the central nervous system. And your sedatives, your alcohol, your benzodiazepines all work by increasing the activity of this neurotransmitter. So sedatives are central nervous system depressants, and they include alcohol, barbiturates, and benzodiazepines. And alcohol is a frequently abused drug among all age groups, and about 10% of U.S. adults are alcoholic. And in adolescence, a bigger problem with alcohol is actually binge drinking than daily drinking. So during parties at school or over the weekends when they're drinking large amounts. Lower socioeconomic groups have a higher incidence of alcoholism. And for alcohol, family history is very, very important. So any drinker has a 5 to 10% risk of becoming an alcoholic. But if you have both parents being an alcoholic, you have a 20 to 50% of chance of being an alcoholic. And if you're a male offspring, you definitely have about a 50% chance of becoming an alcoholic. Now, if your father is a severe alcoholic and a criminal, then there's a 90% risk in the son for him being alcoholic. So you can see that family history is a very important risk factor. So when you're intoxicated with alcohol, your blood alcohol level has to be at least from 0.08 to 0.15, and this differs from county and differs from state to state. And blood levels of 0.40 and 0.50 can lead to coma. But if you are a chronic alcoholic, sometimes even if you have such high blood levels, you're going to be much more tolerant of this. But someone who doesn't drink very often, if they have a blood level of 0.40 or 0.50%, then they are going to go into a coma. Problem with alcohol is that it is frequently implicated in auto accidents, with and without fatalities, homicides. Suicides are also, there is an increased risk of suicide if you're using alcohol because you're more impulsive, you're making poor decisions, and also there's an increased risk of hospital admissions with alcohol. So how is alcohol metabolized? And this is very important for your exam. First, ethanol combined with alcohol dehydrogenase is converted to acetaldehyde. And then acetaldehyde plus aldehyde dehydrogenase is converted to acetate. And the reason why this interaction is important is because we have some medications to help with alcohol abuse independence. And one of them is disulfiram or Antabuse. And what this does is it inhibits the second step, where it inhibits the enzyme aldehyde dehydrogenase. And this is very high yield for your exam. So what happens is acetaldehyde builds up in your system every single time you drink the alcohol. And this leads to nausea, stomach upset, headache, and hypotension. So when you're giving a patient disulfiram, one, you want to make sure that their liver function tests are normal, and you also want to make sure this is a very highly motivated person that wants to stop drinking. And the reason that is because if you take a pill of disulfiram, it lasts in your system for about 2 weeks. So you cannot drink for 2 weeks after that. Also, you have to be careful because some aftershaves, some mouthwashes have alcohol in them and can also produce the same kind of reaction. Frequently, a wife of a patient will say, "Can you give me some of that antabuse or disulfiram and I'll put it in my husband's coffee and he won't know, and so next time he drinks alcohol he'll feel really bad." But what the problem is that the patient won't realize that it's the alcohol that's caused them to have a bad reaction. They might think it's some other kind of food, and so therefore it's defeated its purpose. Asians have a lower level of alcohol dehydrogenase and aldehyde dehydrogenase. So if you've ever gone out drinking with some of your Asian friends, you've noticed that their skin gets pink much more quickly, and they only need a few drinks to get them intoxicated. So what does acute intoxication look like with alcohol? Initially, people will get kind of excited and disinhibited, and followed by getting very sedated, impaired judgment, poor motor coordination. If you drink enough, you can even get respiratory depression, and in the long term, you can have acute pancreatitis. So what are some other complications of alcohol? One is if you drink while you're pregnant, and this does not mean that before you find out you're pregnant, you got to drink a couple of drinks. That does not mean that your baby's going to have fetal alcohol syndrome. But someone who drinks on a daily basis and they consume large amounts of alcohol while they're pregnant will most likely have a child with fetal alcohol syndrome. And this is the third leading cause of mental retardation in the United States. And also, this is a preventable cause of mental retardation because if you can stop drinking, then you can prevent from it happening. So what do these kids look like? And this is high yield for your exam. They have mental retardation, congenital heart disease, wide-set eyes, short palpebral fissures, and mid-face abnormalities, including a hypoplastic philtrum, a very thin upper lip, flattened mid-face, and a short and broad nose. So what are the chronic complications of alcohol abuse or dependence? Malnutrition. Why do you get malnutrition? Frequently alcoholics will sit at home and drink all day long and they won't eat any food. So their limbs, you'll notice a lot of wasting, but you'll notice that their abdomen is getting bigger because of some kind of cirrhotic process or ascites and liver abnormalities. Next, you'll have peripheral neuropathy because of B12 deficiency, more because of malnutrition. Two very important points for your exam are Wernicke's encephalopathy and Korsakoff psychosis. Now, in Wernicke's encephalopathy, this is a reversible condition that can be treated with thiamine. And what does it look like? It looks like altered mental status, ataxia, and ophthalmoplegia. This is a symptom triad, and they're very important points for your exam. Now, for a patient who is an alcoholic, you must always give thiamine before glucose. And do you know why you must give thiamine before glucose? The reason is because in glucose metabolism, thiamine is a cofactor and it helps one of the processes of the metabolism of glucose. So if you give them glucose first, then whatever thiamine is left in their body gets used up for glucose metabolism, and you can actually put a patient into Wernicke's encephalopathy. So anytime an alcoholic patient comes into your emergency room or into your inpatient hospital, always give them thiamine before glucose. And next we'll have Korsakoff psychosis. And you can have Wernicke's and Korsakoff's go together, but what Korsakoff's primarily looks like is amnesia and confabulation. And how you can tell if someone has Korsakoff's is say that they're in your hospital and you come in and you say, "Hi, Mr. So-and-so, what did you have for breakfast this morning?" And you should know what they had for breakfast. And they'll make it up. They'll make up something else that they've had. Or you ask them, "Do you know where you are right now?" And they'll tell you, "Oh yeah, I'm in a supermarket," and they'll make up a very elaborate story. And you have to differentiate this from delirium. Their attention will not be affected. They'll be talking to you as if they're a normal person, but they'll just be making up stories because their memory is affected. Now, what is the pathophysiology of Korsakoff psychosis is bilateral infarction of the mammillary bodies. And this is an irreversible condition. Other complications include cardiac complications such as cardiomyopathy and congestive heart failure, GI problems such as esophageal varices, hemorrhage, chronic pancreatitis, peptic ulcer disease, liver failure, and ascites. These patients are at an increased risk of getting oropharyngeal cancer, esophageal cancer, and hepatic cancer. Also, patients who drink a lot of alcohol will have abnormal estrogen levels, have gynecomastia, impotence, testicular atrophy, infertility. In females, you'll get menstrual irregularities. And because your liver is affected, you could have hematological abnormalities such as pancytopenia, ecchymosis, and coagulopathy. So how are you going to detect a patient in your outpatient setting if they have alcohol abuse? So you can do a very simple questionnaire such as the CAGE questionnaire. So the C stands for, have you ever felt like you should cut down on your drinking? The A stands for, do you ever feel annoyed by anyone criticizing your drinking? The G stands for, do you ever feel guilty about your drinking? And the E is, do you ever need to have an eye-opener in the morning? And what an eye-opener means is to have a drink as soon as you wake up in the morning to kind of steady your nerves to prevent you from going into withdrawal. If a patient has 2 or more yeses to any of these symptoms, then you can be highly suspicious for any kind of alcohol abuse or dependence. So what does alcohol withdrawal look like? Well, alcohol withdrawal can start within 6 to 12 hours after having their last drink. And a minor withdrawal will look like someone having their shakes, their blood pressure will be up, their pulse will be up, and they might have some nausea and vomiting. Usually a benzodiazepine, a long-acting one is usually much more helpful, can help alleviate some of these symptoms. But say some people are very, very dependent on alcohol, and if they stop drinking, they can have much more severe complications. And they can actually have a major withdrawal. And this can occur about 1 to 4 days after their last drink, where they have increased autonomic instability, they are seeing things, especially pink elephants is a big thing that alcoholics see. But at this point, they're not delirious. They're still alert and oriented, but they are very, very uncomfortable. They might even have a seizure. They're seeing things, and their blood pressure and pulse is all very unstable. Also, under major withdrawal, you can have something called delirium tremens, and this usually occurs between 3 to 7 days after their last drink. And again, you'll notice the tremors, the hallucinations, the disorientation, their blood pressure will be elevated, seizures, and if you do not treat this, actually 35% of it can be fatal. So how do you treat someone with a major withdrawal or with someone with delirium tremens is that you have to give them support, give them fluids, give them the thiamine, give them multivitamins, fluids, and you definitely want to put them on a benzodiazepine to help with the withdrawal. And what you'll do is you'll start off with a larger dose of your benzodiazepines, and you will slowly taper them off the benzodiazepines as their symptoms get better. Also, patients are at a bigger risk of having a major withdrawal if they have a lot of comorbid medical conditions. So if they have diabetes or hypertension and that's uncontrolled, that will make their withdrawal worse. So it's very important that you treat any other kind of medical problems. What is the treatment of alcohol withdrawal? Benzodiazepines. No other medication will work except for alcohol. So benzodiazepines will work because they also work on GABA just like alcohol does. Now, if you have a patient that has liver disease, you want to use one of the following medications, either oxazepam, temazepam, or lorazepam. And how will you remember that? It's outside the liver. And what that means is that these medications do not get metabolized in the liver. So if you have a patient on your exam who has liver problems but needs treatment for alcohol withdrawal, think of those 3 medications, oxazepam, temazepam, and lorazepam outside the liver. And if they don't have liver problems, then you can try using chlordiazide epoxide or Librium. And this is a good medication because it is long-acting and therefore it might not need as frequent of dosing. But the problem with this is that if you have a liver disease, then the benzodiazepine can accumulate in your system and you can get the side effects of benzodiazepine overdose such as respiratory depression and further go into a coma. Now that you've gotten the patient out of the withdrawal phase, you've stabilized them, so what are you going to do to treat their alcoholism and prevent relapse? Well, there are a couple of medications that have shown to help. One is acamprosate, which is a glutamate modulator, and this helps to prevent relapse. The only problem with this medication is that you have to actually give it 3 times a day, and most patients are not very compliant with taking a medication when they have to take it multiple times during the day. Another medication that's shown to be very helpful is naltrexone, which is an opiate antagonist. And it is shown to reduce cravings and to reduce relapse by 50%. You can also use disulfiram, which is the aldehyde dehydrogenase inhibitor, which will cause you to have the hypotension, the nausea, vomiting every single time you drink alcohol. Again, for that medication, you're going to need a highly motivated patient. Now, treatment for alcohol is also needed. Medications aren't the only thing that are going to help, but other types of alcohol treatment are going to be very helpful. You can either do inpatient, outpatient, residential, whatever the patient will need. And frequently, an employer referral for treatment is associated with the highest success. So if your employer is telling you, hey, you need to go get treatment for your alcohol problem or you're going to lose your job, you're going to be a little bit more motivated to do it than if just your spouse is telling you to go. Alcoholics Anonymous is probably the largest treatment and probably the best treatment for alcoholics as well. And they have a 12-step program. It's a very religious program, and it provides a substitute dependency. So a patient has dependency on groups and meetings. And you have a sponsor. There's someone there 24 hours a day for you to call and to talk to when you're having your cravings. And it's inexpensive. There are free meetings all over the city. All you have to do is find out where they are. Now, Alcoholics Anonymous can also be called AA. There's another treatment program called Al-Anon. And Al-Anon is not for the patient, but it's for the family members. And what Al-Anon does is it helps family members learn to set boundaries for these patients and help to get these patients in recovery. Next, we'll look at some other sedatives such as benzodiazepines and barbiturates. When you initially take benzodiazepines and barbiturates, you will feel a little bit elated, disinhibited. It'll increase your pain and your seizure threshold. In the elderly and the very young, it can also cause paradoxical agitation, so you have to be careful with this. But if you have a severe intoxication, it can lead to much more sedation, respiratory depression, coma, decreased cardiac output, and hypothermia. Barbiturates are commonly used seizure medications in the past, but we really don't use them very often. And you have some examples in your book. And other uses for them are sleeping aids, anti-anxiety medications, and sedatives. Benzodiazepines are frequently used as tranquilizers, sedatives, anesthetics, anticonvulsants, and muscle relaxants. And they generally have a pretty high safety margin unless you're using them with another sedative. So if you're using a benzodiazepine with a barbiturate, or if you've taken a lot of alcohol and use a benzodiazepine, you really will then worry about the respiratory depression and the coma. Or even if you have like COPD and you use a lot of benzodiazepines, you will be worried. So what do you do if someone overdoses on a benzodiazepine? And this is a high yield point for USMLE. You can give a benzodiazepine receptor antagonist called flumazenil, and this will reverse the effects of benzodiazepines. So how do alcohol, barbiturates, and benzodiazepines help? They decrease stress, they increase your mood slightly in the beginning, they cause sedation, decreased coordination. But on withdrawal of these medications, you have increased anxiety, you can't sleep, you'll get delusions, you'll have symptoms of withdrawal, disorientation, formication, which means you feel like you have bugs crawling over you, depression, tremor, and seizures. This concludes our first portion of substance use disorders for behavioral science and psychiatry for Falcon.